like to introduce the next speaker of the day, Dr. Sakshi Jain. She is a physiotherapist and she's an expertise in cardiopulmonary physiotherapy, and she is the founder of Lymph Breathe, and she has her certification in lymphedema management from ACOLS, and she is also the Beckett clinical method practitioner for breathing exercises also. And over to you, Sakshi.
Thank you, Gyanasekhar. Thank you, Scientifica 2022 for giving me this opportunity. So let's talk, let's move forward and let's talk. So what exactly I want to talk over here is about breathing exercises during cancer treatment. Now, why breathing exercises in cancer treatment is important? Because breathing is multidimensional. So before beginning, I would say that I have no benefits and conflicts of interest during the presentation. So here I want to say, like, breathing has a direct relationship to energy expenditure. So why I say this? Because the breathing rate, rhythm, and the depth and flow of the breathing is directly related to how much energy is being utilized while you're breathing. So it's very important when we talk about cancer fatigue, it's very important that we do energy conservation. And if the breathing is taking a lot of energy, of course, the body is not left enough energy to do other activities. So breathing is not just one aspect. Breathing is having multidimensional aspect, which is biomechanical, biochemical, and psychophysiological. As Anuradha ma'am just mentioned about, there are multiple changes which are happening in different systems of the body when the person is undergoing cancer treatment or is having cancer. So all those aspects affect your breathing in some way or the other way. So in cases, if the person is having less hemoglobin, the person is having anemia, definitely the body is fighting for oxygen, as there is less hemoglobin, less binding of oxygen, but body needs. So in that cases, the person would be having, increased respiratory rate, and many other things would be coming into picture. And that can lead to different change in the biomechanical pattern, because the person might feel like using the chest more to breathe. And that can affect, of course, the breathing and the depth of the breathing and their quality of breath. And that can also, if you're using a lot of your chest and you're breathing really fast, it can also lead to changes with your biochemical. And all these factors together, they can cause more of the stress. So it is interlinked with each other, as there is more of cytokine production and everything in the cancer fatigue. So we need to concentrate on breathing a little bit, and how we can concentrate on breathing and what we aim with breathing exercises is to reduce the level of stress and fatigue, to reduce breathlessness, and definitely to improve the respiratory muscle strength. And how can we achieve this? So first important thing and major important thing is to correct the pattern, which is slow rhythmic breathing. How we can correct the pattern is, if you can look into the diagrams, I mentioned that we can perform this in different postures, but to begin with, it should always start with your supine line with the knees bent, or you can also do it in sitting and progressing to other postures, more active or more upright postures. So breathing, important aspect is you should breathe from your nose, you should breathe slowly, and importantly, you should breathe in the belly. So basically, it's like it is actually diaphragmatic breathing exercise. And the main important aspect here to take into consideration is your breathing cycle, which is inhalation, exhalation, followed by exhalation pause. Now, why exhalation pause is important? Because exhalation pause is very important to stimulate your vagus nerve, and vagus nerve is said to stimulate your parasympathetic nervous system, which in turn will induce relaxation and reduce the stress level in the body. Coming to easing breathlessness, how we can ease breathlessness. We all are physiotherapists, we know about pursed lip breathing. So it is in and out through you breathe in from the nose and you breathe out slowly through the pursed lip. Important aspect is you should not force out your breathing during this. It is a slow breath out. We need to teach patients different positions which help the diaphragm activity and thus help in easing the breathlessness. So it can be like forward lean posture. So forward lean, it is important. The person should not slouch. It's actually forward lean. The back is straight. We need to keep the back straight so that the distance is maintained for the diaphragmatic movement to happen. So they can have a forward lean posture with the help of a chair. So these are few postures. If you see, even in the lying position, as per the patient comfort level, they can achieve these position. And if you all notice, when we get little breathlessness, we have done what we do, we tend to do this on our faces, like even with our hands or something. So this helps in reducing breathlessness, because we get little air, and that helps, stimulation of our nerves. So that is also helpful, that we move air gently on the face with the help of a fan or even hand. Coming to paced breathing exercises. Now, what exactly is paced breathing exercises mean? It's basically coordinating the activities, what you're doing, with breathing. So important thing is, when we are doing some work, it is important that we do not hold our breath. So basically, the coordination of exercises with breathing is very important. So in this here diagram, if you see here, there is demarcation with the blue footsteps and green footsteps, yellow footsteps. So what here blue is, you take 2 steps, and when you're taking 2 steps, you inhale for 2 steps, you exhale for 3 steps, you inhale for 2 steps, and exhale for 3 steps. It is very important that exhalation is a little longer than the inhalation, because during exhalation, as exhalation is a passive process, it induces, stimulates the vagus nerve somewhere, and that can help in reducing the stress responses. So it depends on person to person, and not every person will be having this ratio of 2:3. They can also have ratio 1:2 or 3:4 or 4:5. So it depends. You take 1 step, while you're walking 1 step, you take breathing in, inhale and exhale. And similarly, all this can be included with your activities of walking, sitting, standing, running, reaching out activities. So this is what we say as paced breathing exercises. Coming to inspiratory muscle trainer, it has been found there is a lot of scope of research in this area, but the researchers which are there, the papers which are there, they say that inspiratory muscle trainer can begin as a prophylactic before the cancer treatment starts, during the cancer treatment, and after the cancer treatment as well. So what they prescribe is the maximal inspiratory pressure, whatever the person is giving, the value of the person, it should be 30% of MIP, 30 minutes per day, which you can break down into 10 minutes, into 3 sessions, or 15 minutes into 2 sessions. And it is very important that during this technique, during use, when you are using IMT device, one should breathe from diaphragm rather than using this accessory muscle or upper chest. So it's very important the person breathes from the belly, and it is like 12 to 15 breaths followed by rest period. So if the person is doing for 10 minutes, they take 12 breaths from the device, and then they take a break, then they repeat 12 breaths, and then they take a break. So over a period of 10 minutes, they can do 12 minutes rest, 12 minutes, 12 breaths rest, 12 breaths rest, like this. So it has been found, when the inspiratory muscle trainer is being used, it helps a lot in terms of taking lung care, keeping the lung healthy by keeping the muscles which are, because somewhere the drugs which are being given to the person, or the cancer fatigue, also affects your diaphragm muscle. So what is important in this is, breath holding should be avoided at any time, and especially during activities, breath holding should be avoided. So there are supporting literatures which are telling that yes, breathing exercises are helpful even during the treatment and after the treatment, but they definitely need more researches, so there is a lot of huge scope for research in this area. So thank you. Over to you, Gyanasekhar.
Thank you, Sakshi. It was a quick session because of the time constraint, and thanks for a lot. And as I told, the questions will be answered on the later session. And now I am over to Dr. Sharon Purata. And Dr. Sharon has done her PhD in Newcastle University, United Kingdom, and she is practicing her oncology rehabilitation for past 10 years. And now currently she is working as a therapist in the department of JRU Sarcoma Unit in Royal National Orthopaedic Hospital. Over to Sharon.
Thank you, Dr. Gyaneshwar. Thank you, Scientifica, for giving me this opportunity to come as a guest speaker at this symposium. I'll just share my screen now. Yeah, so today I'll be talking to you on the topic of functional outcome and quality of life issues amongst cancer patients. Can technology transform rehab care? I'm Dr. Sharon Furtado. I'm a senior sarcoma research physiotherapist from the Royal National Orthopaedic Hospital and the lead on the musculoskeletal cancer rehab program. So impact of cancer on functional outcomes and quality of life has already been touched on by my previous speakers. Cancer is disabling and debilitating. I'll be going into further detail of how function and quality of life is really affected. So cancer treatments lead to significant issues. We know it's a life-changing event. It often causes lymphedema, pain, falls, and outcomes are often poor. We also know that people fall a lot due to disability levels and huge number of impairments. There's an impact, as I mentioned, on function and quality of life. Physical activity, which is one of the most affected in cancer, is also known to be linked with really important outcomes, such as survival. That means the overall survival of patients depend on whether they are more or less physically active. If they are more physically active, it's known that the survival is better in patients, and this is shown in some systematic reviews already. One example is Barbaric et al. In 2010. So how can we then assess these outcomes and how should we be treating them? Often in clinical practice, we tend to see our patients, we usually assess them subjectively. We often don't use outcome measures routinely as part of practice, but actually using outcome measures is now a very important aspect of managing care worldwide. So the biopsychosocial model, which is the International Classification of Functional Disability and Health, which we all know about, is the ICF. It's widely recommended by the World Health Organization to use to measure outcomes and also to inform management. So what are the different outcome measures we can use then? There are subjective ones, which we all know are questionnaires. There are cancer-specific questionnaires for different types of cancers. For example, for breast cancers, you'll have totally different questionnaires sometimes compared to musculoskeletal cancers or compared to prostate cancers. There are clinician-based assessments as well, where a clinician or a physician will measure outcomes in an individual. Now, these can be often subjective. That means they do not give us a single number usually to work on. One would argue you get total scores, but sometimes they're not as good because it can be quite subjective based on what a patient answers or what a clinician measures. Objective technology, on the other hand, can help bridge this gap. So basically, we can use technology, both lab-based ones. So we all have heard of lab-based systems in our sports setup, but these can also be used for onco rehabilitation, and it is being used currently across the world. We can also use more usable technologies which are portable and not as expensive or laborious like lab-based technology, which are more remote monitoring technologies. I'll be talking around musculoskeletal cancer and how we can use it as an example to show you what outcome assessments we can do for MSK cancers, which can talk to other cancers as well, or you can replicate the methods in other cancers, and also how do we inform rehab. So the different types of questionnaires for functional outcomes in MSK cancers, I'll give you an example. These are 3 questions of one questionnaire where patients are asked, are you able to kneel? How difficult is it? Are you able to bend or pick up something from the floor? How difficult is it? And again, are you able to walk up and down stairs? There are 33 questions in this questionnaire. I won't go into detail, but it asks about functional activities. Similarly, for quality of life, some of us or most of us must have heard of the EORTC, that's the European Organization of Research and Treatment in Cancer Care, Core Quality of Life Questionnaires, QLQ-C30. It asks about the different elements of quality of life, such as about fatigue, nausea, vomiting, pain, dyspnea, insomnia, appetite loss, constipation, diarrhea, and also what financial difficulties are our patients facing. However, as I mentioned before, if we look at that, it's all subjective. It's all the patient's perception, their recall. Are they remembering correctly what they feel? And whatever we're measuring, is it really the true reflection? So technology, how can we use technology to objectify our measurements or to quantify what we really are, what our patients are really facing? What are the possibilities? So this is an example of a lab-based technology or a motion capture laboratory, which comprises of a treadmill on which a patient walks. And then it's usually, we know Vicon. Vicon is a marker-based system, as I said, used in sports, but it's being used in cancer as well. And the person is looking at virtual reality, and then they can do their movement. So they can walk on the treadmill. What we can measure balance and gait outcomes, kinetics, kinematics, and also other functional outcomes. Assessments can be completed at 3 months and then at 9 months, or at any time point we wish to assess patients. I'll be giving example of a 3 and a 9 month assessment. This is a 34-year-old adult male who's a bone cancer patient, who's got the cancer in the right hemipelvis or ilium, so in the right pelvis. This is their pelvic anterior tilt. And if we observe the red and the blue, it is actually the assessment at 3 months. You can see that compared to the gray mark, it is very far away. So it's quite low. The gray mark is healthy individuals, or the gray sort of wider line, this part. And then the orange and the green is the 9 month assessment, which is going more towards the healthy individuals. So the patient is improving from 3 months compared to where they were to 9 months, going into the grayer area close to healthy individuals. Also, we found in this study, which we did, that hip rotation, thoracic forward flexion, shank and ankle rotation, and foot in toeing was also affected. So in patients compared to healthy individuals, you can find that there are lots of gait kinematics affected in this musculoskeletal cancer patient. Similarly, for other cancers, we should be doing such assessments to understand how their physical activity, balance, and gait is affected. These are new lab-based technology approaches. They can help identify high-risk patients early. They can quantify rehab, help us deliver personalized rehab. And it can also aid mobility, reduce falls risk. As you can see, this individual is being challenged by the treadmill while he's walking in a virtual reality environment. And this can really inform personalized rehab for this patient and improve their quality of life. So what are the limitations of these laboratory systems? They're quite expensive, we know. They need a big space. They are cumbersome and they are not portable. So what can we do to measure outcomes in patients' homes, which is closer to them? Can we have more portable systems, and what do they look like? So the answer is yes. We do have portable systems and technology being researched in the world at the moment. This is one example, the Microsoft Connect. Some of you all must have heard that children, you all might be knowing people who have the Connect technology where they can actually use it for gaming and for doing different exercises. Now, this is an example of a person who's doing a movement in front of the Connect, and the left side is the skeletal model of that person moving. Using this, you can measure different functional outcomes of that patient. Isn't that exciting? And if you look at the second one, this is a person on whom we put an accelerometer on their lower back. And then you ask them to do standing or walking, and you can measure their balance, their walking outcomes, and also any other functional outcomes which might be of interest if you work closely with engineers. So these are such small devices like a matchbox, and actually they can be given patients to take home. What can these same small devices called accelerometers measure in the community? And we also know about the Fitbit and mobile apps. So these are Fitbits, mobile apps, which nowadays we are seeing often most people having. They are going for their jogs, they are going for their walking, and you see them monitoring their steps. And this is exactly what we are going to measure using these devices. So this is a person walking with the accelerometer on their thigh. And when they walk, you can see that we can measure walking physical activity, the volume of their activity, that is how many steps they take, how many hours are they walking for, sitting or standing, and also are they lying a lot and just sleeping? As all the previous speakers spoke about fatigue and different problems like breathlessness, we saw that that can cause people to become less physically active. So can we use these devices to measure their physical activity and then to give them feedback and biofeedback to ask them to improve it? This is one last example of this accelerometer-based assessment, where at the bottom we can see a graph. The blue part is a person in lying. They're lying down from 12 to 6. That means they're sleeping probably at that time, which is all right, which is a normal thing to do. But if you see the other parts of the activity, the yellow part is often if they're sitting, the green part is if they are walking and their number of steps. And then the red part is their number of steps. That means they're walking. So you can tell how physically active the person is by just looking once at a graph And this is showing a week's physical activity from 21st June to 27th June. But you can actually see this for a month, even for a year for patients. So you can immediately look at a patient's graph and say, oh, are they physically active, or are they sleeping a lot, or are they sitting a lot, or are they walking a lot? Now, we have done some studies, and I'll quickly just tell you in short. The main findings were that we published this paper as well, so feel free to read it if you wish to. But it's our accelerometer-based functional outcomes assessment and feasible after treatments for lower extremity musculoskeletal cancers. It won an award in Scotland and in New York at national and international conferences. So what we found is balance and gait is affected compared to healthy individuals. And it is also, it predicts disability and poor quality of life. So if you have impaired balance and a person is falling very often, it often predicts TESS, which is the disability measure, and quality of life, which is a quality of life aspect. Same with gait. It's quite surprising to see that, again, it predicts disability. So someone's not walking very well, they would be highly more disabled, and also their quality of life experience would be really poor. So it's important to understand that functional outcomes are important because they affect important aspects of people's lives, their quality of life, their survival. So we need to actually study these outcomes more in patients, and we need to really assess them as we're going along the clinical pathway of the cancer journey. Now, what about quality of life? It's a major issue. So sorry about presenting a little complicated slide, but the main part to say here is people's physical health, social health, and mental health is affected in quality of life. Often in physical health, the physical condition, how they are walking, their functional outcomes, which I spoke about, their mobility, their prior health, fatigue levels, what we spoke about already, sleep problems, all these are physical health issues. Also, how much in pain are they? Their social health issues are things like social activity limitations. So are they going and meeting their friends and families? Are they quite isolated? Are they going to employment and their job roles, or are they just sitting at home? Their mental health, are they feeling anxious and depressed, or are they actually feeling full of energy? And all these things matter when the quality of life of a person matters. And our cancer patients are going through a lot. So they must be supported. We must assess them right from the start. So cancer rehabilitation. Now, just to talk about this element, it's very important, because what's the use of just assessing all outcomes and then not treating it? We need to treat this. So a framework for assessment in oncology rehab has been suggested by Gilchrist et al. And also in another study in breast cancer, put both the references here. But basically, they've suggested using an ICF model, because a cancer patient's journey, as all my kind previous speakers spoke, is not easy. There are holistic outcomes which are affected. That means lots of issues. We need to assess them comprehensively. And biopsychosocial models could be the answer. So how technology and biopsychosocial models can inform rehab is what I've suggested here. This is what we've done. We've done some work in musculoskeletal cancers, where we measure an ICF-based multi-dimensional assessment. So we measure their impairments, their activity limitations, their participation restrictions using a combination of questionnaires plus accelerometers. And we can then measure what is their environmental factors by asking the patient personal factors and contextual factors. Using this, we can then develop what are the treatments. So if their range of motion is affected, you give them range of motion exercises. If their muscle strength is affected, you give them muscle strengthening exercises. Now, it all goes like our normal clinical practice. But what it gives us is a framework which is evidence-based to measure all these different components which can be affected. And that is the part which makes it structured, comprehensive, and evidence-based, compared to sometimes where we are not collecting these outcome measures and not embedding them as part of such models. Also, activity restrictions, reminders to increase physical activity levels, exercise and fitness in their homes, their home exercise programs. And for quality of life, you can use things like referring them to sports or wider participation or return to job or return to school if they're children. And how can we use ICF again? Just a quick example, you put the questionnaires, as I mentioned, your physician-based assessments, you combine it with technology, and then you can develop personalized rehab programs for these patients. In our study, we've shown that this significantly improves their outcomes such as return to normal living when we have done a pilot study. We plan to do a national and a larger international study with all our centers, our global centers we are working with. So in summary, functional and quality of life issues are common after cancer treatments. They include impairments, disabilities, ADLs, that is activities of daily living are affected. Return to normal life is affected, employment, education, and sport. They need personalized rehabilitation. Biopsychosocial models like ICF and technology can really revolutionize the multidisciplinary care for our patients and the physiotherapy care. They can identify high-risk patients early and treat them early. So we can really improve the experience of our cancer patients because they're already going through a lot. And it can inform clinical decision-making. This can be the experience of our patients if we see the below two pictures. And in short, we have the potential to really revolutionize and improve the care for our patients. So let's do it. So thank you for listening. This is the end of my presentation, but especially thanking our centers who we work with, which are national centers, international centers, also Tata Memorial, who we've developed links with and are working, and Netherlands, and also our cancer charities for funding the work, our patients, and all our teams. And if any questions, please contact me on this email address, but please feel free to post any questions here. Thank you, Gyaneshwar. Back to you.
Yeah. Thank you, Sharon. Thanks for the brainstorming sessions we had. And the next sections are already piled up. So we will be skipping the question sessions. And we will be giving the mail IDs to the fellow students so that if they want any questions to be shared, they can share it us on privately and we can answer them directly to them. Over to Prajakta.
Thank you so much, all the speakers. I know the topic is very vast. Thanks for giving a gist of the topic and not missing the crux of onco rehabilitation. I think we tried to cover it very comprehensively. Thank you so much to Dr. Gnanasekhar for wonderfully steering through the session. And of course, obviously, to our wonderful audience for keeping the patience and being there. We'll be concluding with this symposium on onco rehabilitation. To the audience, stay tuned. We'll be starting with another wonderful panel discussion in auditorium. Thank you so much. Have a wonderful day.
Thank you. Thank you.